going to go ahead and get started again. For those of you that were here last year, if you remember, we had Molly Lopez here for the UT Center for Excellence in Mental Health. She did a really great trauma-informed care presentation for us, and so in our planning this year, we decided to follow that up, and so this is the first of 2 trauma-focused presentations. So now I'd like to introduce Tim and Bettina Job. Tim Job is the program director, and Bettina Job is the clinical director at Spirit Reigns. Spirit Reigns is an outpatient counseling center offering a variety of innovative professional counseling services. They specialize in trauma-focused equine-assisted psychotherapy in serving children and families who have experienced abuse, neglect, or other traumatic events. They're also the founders of Natural Lifemanship, a training organization that teaches a comprehensive model of equine-assisted therapy that employs both the physiology and the psychology of the horse to address specific therapeutic goals with children, adults, and families who suffer from trauma-related mental health disorders. This model of TFEAP was developed by Tim and Bettina Job and is a culmination of over 45 years of combined work with children, families, and adults whose lives have been touched by trauma. Please help me in welcoming Tim and Bettina Job.
Thank you.
Well, we're so glad to be here. So Tim and I on the way here were really focused on how to make sure that we keep this to an hour, and we were told that y'all have lunch right after this, so if we were to run over, you'll start throwing stuff at us anyway. So we're gonna be succinct. So Tim and I are actually here today wearing a couple different hats, and so Matt talked about that just a little bit. We do, I like to kind of define those hats for people just so they have a little bit of an understanding of what we're going to be doing today. So the first is that we are the founders of a training organization called Natural Lifemanship, and we travel about once a month all over the States. We do a little bit international, training people to do the type of therapy that we do at Spirit Reigns. That's not what we're here doing today. We'll define the difference there just a little bit. So when we are doing training, we're wearing Natural Lifemanship hats. And then I'm the clinical director, and Tim's the program director at Spirit Reigns. And Spirit Reigns is, it's in Liberty Hill, so it's not too far from here. And when we're providing services, when we're providing counseling services, when we have that hat on, we're doing that at Spirit Reigns. That's our most full-time job. And so today there's a couple assumptions that we make here. We are not here to train y'all to do equine-assisted psychotherapy. So our assumption is that every single person in the room has maybe never even seen a horse. In Texas, that's not real likely, but that still happens. So we assume you haven't seen a horse and that you're never even going to be around one. So we're not teaching you how to do anything with horses. So what we're going to do this morning is we're going to introduce y'all to some of the basic concepts of how we conceptualize a lot of mental health issues with the families and the children that we work with. Trauma is our filter, and why it is that horses, because of the development of a horse's brain, how that then helps us be able to more effectively work with these children and families that can sometimes be very treatment resistant. So I'll let Tim take over here for a second. Well, no, you mean to talk? I mean, never mind. We're working out which slides we would do. Okay, sorry. Never mind. That's not your turn. Sorry. We're used to talking for 3 days. We have to get really organized when it's an hour. So I gave y'all there's 2 slides on your handouts that have a overview of everything we're going to talk about the remainder of this presentation. But the down low, when we're talking about trauma and we're defining what that is, so I know if y'all learned about the ACE study last year, you learned a ton about how we define trauma and what are the long-term effects of that. So what we really do to break that down is we talk about how when we're talking about trauma, we're talking about any situation where survival is the overriding concern. The longer that our kids spend time in situations where survival is the overriding concern, then their brain starts to make some changes to accommodate that environment. And it's really a great survival skill. And so that's going to affect their ability to be able to self-regulate or be able to control themselves. And that affects their ability to have good relationships with others, but also relationships with themselves. And so we're going to go today into some real general how does the brain develop and how trauma changes that. And then we're going to talk about some of the principles of behavioral interventions that we teach families at Spirit Reigns. All right, so the brain develops from the bottom to the top. So this is a cross section of the brain. If you look at the very bottom here, where you're seeing the spinal cord, this is the brain develops there first. It's going to develop there up into this part called the diencephalon. So you see that little P-shaped thing in the middle of the brain. That's where your diencephalon is. As you move up in the brain, you get into the limbic system and then into the neocortex. So the important thing to know here, and we're going to go in a second, we'll talk about the different parts of the brain, what each one does, is that if the brain stem, the very bottom part, does not develop appropriately, and the majority of this is happening in utero. So when a woman is pregnant, that brain of the baby is developing during that time. Sometimes we forget that there's so much of that brain development that occurs before we're even, we work with lots of adoptive parents that say, I adopted them at an hour old, and they're having these struggles, and my biological kids are not. So this is all happening, the development of the brain is all happening in utero. And if the brainstem does not develop appropriately, it's sequential and it builds on each other. The very outer regions of the brain, the part that's closest to our skull, that area is called the neocortex. That part of the brain is not going to develop either. And that's really important when we start talking about what those different areas of the brain do. So this is a little bit of what I just now said, so y'all have it in your manual. And the idea is the simplest part of the brainstem develops first, everything else. There's a cascading effect. Okay, brainstem doesn't develop correctly, neither will the diencephalon, neither does the limbic system, and neither will the neocortex. So the brainstem is the area of the brain that we typically, when we talk about survival, that's kind of the area of the brain we're talking about. So really reflexive things are happening in that area of the brain. So the brain stem is responsible for arousal, sleep, blood pressure, our temperature, the way our heartbeat. Most of the time breathing is actually occurring in the brain stem. Most of us don't think about breathing all the time. We can take some of these functions and put them into different areas of the brain. So these are going to be your more reflexive areas. That's the first part to develop. The second part of the brain is the midbrain, or the diencephalon. That's that little area where there's that little P. And that area of the brain is responsible for motor regulation. Then as we move into the limbic system, this area is really important because it's developing after the brainstem. And this part of the brain is responsible for really relationships and attachment. This is the area that most of the time what we're talking about is the emotion regulation occurring in this part of the brain. And then the very last part of the brain to develop, the most complex part of the brain, is the neocortex. That's the part closest to the skull. And that's responsible for abstract and concrete thought. So when we are attempting to educate children, the assumption is that they have the ability for concrete and abstract thought, that they're able to learn. In order to do that type of learning, the outer areas of the brain have to be engaged. Okay? So this part of the brain is often very underdeveloped in trauma. We're going to talk about that just a little bit more in a second. You want to take that? I've been talking for quite a bit.
Yeah, I'm not really here just to be the pretty one. And I know that can be confusing. What causes the brain to start to develop in utero is the sensory input from the mother. That's the only sensory input that the brain is getting in utero, and it's the rhythm of mom's heart rate, the rhythm of her breathing, the rhythm of her brain waves. And if for any reason those are interrupted, are not real predictable, or not real rhythmic, then it's going to have a debilitating effect on the way the brainstem develops in every area after that. So if my mom is on drugs and her heart rate is all over the place, her breathing's all over the place, then to that fetus, the brain starts to think, I'm going to be born into a war zone, and I need to be able to survive in a war zone. So the parts of the brain that are going to help it be able to react instead of respond are going to be better developed. After the baby's born, then all the other sensory input that starts to come into that brain develops certain areas of the brain. And this is where neglect gets to be a really big problem, because it's that sensory input that causes each area of the brain to develop. The brain's like a muscle. If you don't use it, what happens to it? It starts to atrophy, and the same thing happens to your brain. The more a system is activated in the brain, the more neurons are going to move to that area of the brain where they're going to be used. So if I'm laying in a crib and no one ever comes to talk to me, no one ever turns the lights on and off, I don't see anything different all day, I don't hear any different sounds all day, then those areas of my brain are not going to develop, because I'm not getting the sensory input I need. If I cry and no one picks me up and helps me feel better, then the areas of my brain that says relationships feel good doesn't develop. If someone comes in and smacks me because I'm crying, then my brain develops to tell me relationships make me feel worse. So it's the areas of your brain that are activated that are going to develop. And this is, you can start to see some of the problems that our kids come into your classrooms with, because their brains are not developed to the point where learning is really a thing that they're even capable of.
Yeah, one of the steps in brain development, one of them is called migration. And what that's talking about is that when a baby is in utero, neurons are born. Okay, that's neurogenesis. So neurons will be born. And then at some point, they have to move to the area of the brain where they're going to be used. And what's supposed to happen in a predictable environment, and that's part of what Tim's talking about, if the world is predictable, the mother's heartbeat is more rhythmic, that there's some rhythm occurring within her body, that about 50% of the neurons are actually going to move to the neocortex, to the outer parts of the brain, which is what's supposed to happen in brain development. But we've got kids who are living in somewhat of a war zone, in utero, really. And so more than 50% of those neurons will move to the lower regions of the brain. So we have fewer neurons at birth, many times even into the neocortex. So we do know, when I first started learning a lot of this information, I was getting my master's in counseling. And we had a teacher that explained all of this. They explained to us in detail kind of what happens when there's severe abuse and neglect, and explained kind of the brain damage was the language being used. And at the time, the general idea was that cannot be fixed. There's nothing we can do about it. We know now there's a lot that can be done about it, because if the brain can, we even know now that neurons will continue to grow throughout the lifespan. People in their 70s and 80s, when they have new experiences, they can get new neurons and they can move to new areas of the brain. So our brain can get, the plasticity of the brain is what you'll hear talked about in this neurobiology field. And so a lot of the children that we work with, they have, at this time, the areas of the brain that are activated are the emotional centers and the survival centers. And that explains a lot of the behaviors that we see. Even at Spirit Reigns, we have a large number of kids that come to us with an ADHD diagnosis. And the majority of them, we can really trace that back to a trauma issue. What's really going on is the survival areas of the brain are what are engaged all the time. And so they're fidgety, they're hypervigilant, they're watching everything in their environment all the time, trying to see what's going on, and the smallest thing sets them off.
And that's why we use horses, because a horse's brain develops pretty much the same way that a kid who's been through severe trauma develops. Everything is happening in the lower regions, in the survival parts of the brain, and there's not many connections into the neocortex. Because if I'm going to survive, I need to be in the lower regions of my brain where movement happens, where emotions happen that cause the movements, and where rhythm happens to make me move more effectively. So a horse is born with a less developed neocortex, just like our traumatized kids will be when they come into a classroom. Their brain is not developed the way that a kid who's had a very predictable environment has. So we use horses because in the kids helping the horse develop their neocortex, because that's what horse training is where we're doing it, is we're wanting the horse to learn how to think and make decisions, and we're wanting them to engage their neocortex, make as many connections as they can up into the neocortex so that they can make better decisions about what happens in their relationships.
So one of the things we haven't really said yet is we're talking a lot about self-regulation, is that language we're using, self-control. So in order to be able to control yourself, we've implied it, but in order to be able to control yourself, what really has to happen is the neocortex that's responsible for thinking has to be able to override what's happening in the lower regions of your brain. For that to occur, if we use real rough terms here, there has to be an actual road going from one area of the brain to the other. And so what we know in trauma is that because the survival and the emotional centers of the brain have been so engaged, and they haven't had to utilize the neocortex as much because they've been in those survival situations, that the connections from the lower regions, the cross-brain connections, those are compromised. And so without those cross-brain connections, I actually cannot override what's going on. And that's what's going on with the horse all the time. If you look at this picture of the brain, where it's pointing to the cerebellum, that little round thing way over there on the left, that's part of the brain stem. That's huge compared to the remainder of the brain. From a percentage perspective, that part's really big because the brain stem is developed to be bigger than other areas of the brain, so they can, because they're prey animals, horses are. And if you think about it, so many of the kids that we work with, they have, we like to think of humans as predators, like we're the top of the food chain, but that's really not the case when trauma has occurred. So a lot of our kids have been prey animals, and their brain looks a lot like a prey animal's brain. I believe this is kind of all what we just said, so you'll have it in writing. Let me take it? I'll talk first. Okay, so we're going to talk here for quite a while. This is one of our absolute favorite things that Dr. Bruce Perry has put out. Are y'all familiar with Dr. Perry? Tim and I have done lots of learning with some of the people we consider sort of giants in this field of trauma. And Dr. Perry is very focused on child trauma. So if you haven't done any learning with him, he's got great, great resources on his website. And this is my most favorite thing that he's put out. And so this is the arousal continuum. So we're going to just kind of walk through this and talk about everything we've discussed so far. It's all sort of listed here on this chart. So if you look at the very bottom, that's our internal state. So state is what's your mental state. It's meant to be something that's temporary. So if you move across that, it's calm, alert, alarm, fear, terror. The hope is that everybody in this room we're making an assumption because we're teaching you, that everybody here is in a state of calm or alert, hopefully. Because if you move up the column there, you'll see that when you're in a state of calm, you're able to do abstract learning. That's the cognitive style. Okay, because if you keep moving up, it's the neocortex that's engaged. Okay, in a state of alert, you can do concrete learning, and still your cortex, the outer regions of your brain, are still the parts that are engaged. Okay, but at any given time, something could happen. You know, we could start to hear some noises outside. We don't know what's going on out there. We may start to, if we heard lots of, some ruckus going on out there, we may start to move up the arousal continuum a little bit. We'd all go, what's that? What's going on out there? We'd move up to a state of alarm. And if at some point somebody with a gun or something opened up that door and started threatening our lives, we would move to a state of fear or terror. A different area of our brain would be engaged, and we would do what we needed to do to survive. That's normal. We all do that. So these internal states are something that every single one of us can experience at any given time.
And that's what being born into a war zone means. I'm born in a state of alarm. My brain is on alarm all the time, so every little movement, every sound, every little bit of increase in stress is going to feel dangerous to me. Every request that someone makes of me is going to push me further up the arousal continuum into either a state of fear or a state of terror, and I'm going to react out of those states. And it's sometimes just walking into the classroom pushes them up the arousal continuum and makes it where they can't learn, makes it impossible for them to learn.
Yeah. So really at the core of traumatic stress, what we're talking about is if in this situation where something came in and threatened our lives and we moved up the arousal continuum, the hope would be that over a certain amount of time, not within the next hour or two, in fact, knowing what we know because we have common sense in this room and also what we know about trauma, we would probably cancel the conference for the remainder of the day. It wouldn't be like, oh, the gun person's gone, so everybody sit down and just kind of let that go, and we're going to just move on. We probably wouldn't do that, okay? If something that traumatic were to occur, the conference would probably get canceled for the rest of the day because we wouldn't really be in a state where we can learn anymore. But with most people, if we checked in with y'all 2 or 3 weeks later, what would happen is you would be able to come to a place where when the environment is calm, you're able to be calm, okay? Some people might develop PTSD symptoms. And what we're talking about when we talk about PTSD symptoms is that you're going to get stuck in that state of alarm. That's what Tim just said. So it's the way Perry talks about that, as he says, a state, something that's temporary, becomes a trait, something that's permanent. So that what happens is you're sitting at home, in the morning you're trying to have a cup of coffee, your house is nice and calm, there's really not anything that's threatening, but you're still on high alert because you're still worried that somebody could come here any minute. And that's really what we're talking about when we start talking about post-traumatic stress disorder.
And it also starts to interfere with your ability to smoothly shift from one state to another. So you're sitting at home drinking your coffee, everything's nice and calm, and you're able to be in a state of calm. But your wife comes in and says, did you feed the dog? And instead of going up into a state of alert and saying, oh, no, I forgot, I'll go feed the dog, you shift from a state of calm up into a state of fear. And you're going to react out of a state of fear. And as you can imagine, that might damage your relationship a little bit.
That is just an example. That really doesn't happen at home.
No, I never feed the dog.
I do that in the morning. Okay, so I'm going to move to the next slide, but we're coming back to this one, so just kind of hold those 2 spots. Because we've got several quotes here from really smart people, so you don't think we're making anything up. Talk about what exactly we're discussing here. So Dr. Frank Putnam is the very top guy there, and we really love him, but he doesn't, as far as we know, do trainings for people, or he's just done written so many things, and done lots and lots and lots of research, and he's really smart. If you need good falling asleep reading at night, he's good for that. But he was the person to coin this term state change disorder. That's what we were just talking about. And What he says, if you look at that second sentence, is trauma disorders can be seen as problems in maintaining states relevant to context. Okay, so that's what we're saying is I'm in a state of alarm even though the context, the environment is calm. And in smooth state shifting, and that's what Tim was just talking about. So instead of slowly moving up that arousal continuum, you go from calm to terror or fear. It's just a massive jump. Okay, Tim and I have also worked with veterans in the past, and that's what we see all the time. You know, a gun goes off somewhere, and they're underneath the table. Not a gun, a plate. A gun would make anybody. Yeah, some noise results them under the table. Bessel van der Kolk says that the core of traumatic stress is a breakdown in the capacity to regulate internal states. And then Dr. Perry's is nice and catchy, and he says that a state becomes a trait. Okay? So the other thing that we only have maybe a couple minutes to spend time on here is we've talked about those bottom 3 rows. I want you all to take a peek at the other 2 rows. They're pretty important. And we don't have a lot of time to go into these in great detail. But when trauma occurs, our kids are going to, there's going to be sort of 2 different coping mechanisms that they're going to use in order to appropriately deal with that. Okay? One is to be hyper-aroused, and that's the arousal continuum you're looking at there. These are the kids that we get referred to therapy a lot because their behaviors are more outward. Okay, and they're really much more annoying because if you look, remember our clients are stuck in a state of alarm. Move up that column. If they're on the arousal continuum, that means they're resistant. And as they move up it, they're defiant and then they're aggressive. And this is a problem for teachers, for parents, for whomever is involved in this kid's life. Dissociation is the kid that tends to fly under the radar. We don't see these kids a lot of times until there's been some reports made of problems in school. We'll see massive IQ drops in some of these kids because in a state of alarm, they're compliant. So when we talk about dissociation, the general idea here is that our kids start to basically check out from whatever's going on. Okay, it's much more common in girls, and it's really common with children who've had a sexual abuse history. So the environment, the trauma is so great that I can't handle it. And so you'll hear kids talk about that they black out, that they check out, that they zone out. We've heard them say that they feel like it's an out-of-body experience where I'm almost floating and I watch what's happening, but I don't feel it. So what the problem here, the good thing is that it works really well in that traumatic situation. You know, Tim and I often sit in intakes and stuff and we think, you know what, if these kids hadn't dissociated, we would have had suicide, I think. So it's such a great coping mechanism. It helps them bring their heart rate down. We do a lot of biofeedback at Spirit Reigns, and we see the ability that dissociation does to help them calm down. The problem is that they're doing that by checking out.
Which means they're blocking all sensory input, which is what develops your brain.
Including learning. So these are the kids that if we can catch them, and you'll see they're real compliant. And that's why they kind of fly under the radar, because they don't bother us. They don't bother you in the classroom. They don't bother parents because they kind of are doing what they're supposed to do. But it's a little bit robotic. That's what you're watching for. And then they will, as they move up that arousal continuum, they move into where they'll sometimes start that fetal rocking, that almost kind of stemming behaviors. We have lots of kids come into our program that have been diagnosed on the autism spectrum. And if this is really what's going on, that if we can help them figure out how to be present and start working through some stuff, that we see some of those autism symptoms disappear. And then fainting is the last. You will see kids that tend to be pretty dissociative, that if you stress them out enough, they're going to move into the hyperarousal. So they can jump between those two. So this is something to kind of watch for. Those dissociative kids get lost. So this is a summary of what we just talked about. So when we're talking about trauma, because we're about ready to start talking with you all a little bit about the principles that we really start to employ when we're working with these kids. So this information we just gave y'all, it's out there. So it's not brand new information. Some of you've probably heard it before. What we do with this information is really different depending where you learn and who you talk with. And I think sometimes we use this information at Spirit Reigns a little bit differently than people are accustomed to. So the information is that in trauma, the lower regions of the brain are what are engaged. And the other thing we're looking at is lack of cross-brain connections. So if we're asking them to, their whole brain has to be at work if we want them to learn. And mostly the neocortex has got to be engaged for us to teach them anything. So we're about ready to talk with you all a little bit about the way that we use this information. And our work with horses greatly informs this. Tim and I lived in New Mexico for a while. And Tim did most of this work. I did a little bit. But we're working primarily with wild Mustangs, horses that had been pulled off of in New Mexico, they pull them, the BLM pulls them out of the wild. And it was our job to gentle them and get them ready to go to be adopted into different homes. And those horses were scared to death, absolutely in a state of fear and terror. The minute you got in the pen, it's the first time anybody had ever been in that pen with that horse. A lot of that work is what informs what we do with kids, because what we know has happened because of the trauma field, all of that information has made people go, well, they have no control then, right? These kids, their neocortex not engaged, they can't help it. So we just let them do whatever they want. There's a lot of that very almost kind of permissive things that have happened, and it's been disempowering. We've worked lots and lots with parents and educators who will tell us, well, we can't do anything with these kids. And you can, and we're going to talk about that part today and talk about what's happening in the brain. And we're going to be going back and forth between horses and people because their brains look really similar.
So,
these are a lot of the readings and references and places that you can go find more information. Okay.
So where we start is, like with those Mustangs, I could go into their pen and they're immediately going to go into a state of terror. And they're going to start running wildly around that pen, or they may even try to attack me because they're in a state of terror. I could leave the pen. What's that going to do? It's going to teach them that being in a state of terror gets their needs met. So I'm not going to leave the pen. I'm going to stay in the pen until they figure out how to bring themselves down that arousal continuum. Because just the pressure of my presence is enough to make them start to hunt a different answer. Because this answer of being in a state of terror is not getting my needs met. So I'm going to have to figure out how to bring myself down that arousal continuum and engage my neocortex to figure out what to do with this pressure of this human being in my space.
Real quick, before we get into this too far, what we have on your slides right now is going to be just pictures, and we're going to talk. There's another handout that y'all have next that's going to go into what we're going to talk about here in great detail if you want it to reference later. So feel free just listen, see if it makes sense, and then you have that to reference later that'll have everything we're talking about, several pages of it. Okay?
So on that arousal continuum, when they're in a state of fear, they're going to be defiant. If they're alarmed, they're going to be resistant. So when I go into that pen with that horse starts running around that pen because he's in a state of terror and he's trying to get away. When he can't get away because he's in that round pen, then he can't run forever. So he's going to start thinking, what am I going to do? And when he starts thinking, then he starts coming up with solutions that he's going to try. If I remove the pressure while he's in that resistant, defiant mode, then I'm teaching him that being resistant gets the pressure released. That's not what I want to teach my horse. So I'm not going to release the pressure. Now, I'm not going to increase it enough that he wants to jump out of that pen or do something to hurt himself either. So there's different things that he can do, but there's really only 3 things he can do when he feels that pressure of me being in that pen with him. He can ignore that pressure, which in his brain he's not capable of doing yet. He can resist that pressure, which is what that wild Mustang is going to do. Or he can cooperate with that pressure. Anything that he's going to do is going to fall into one of those 3 categories. And there's only 3 things I can do. I can release the pressure, I can increase the pressure, or I can keep it the same. Those are the only 3 options I've got. So whichever thing he does is going to determine which one I do. So if he's resisting and I release the pressure, I'm going to teach him that resisting makes the pressure go away. And I'm going to start forming a connection in his brain that says resistance makes me feel better. And that's what's happened to a lot of our kids. They've learned that I can resist enough that everybody will take the pressure off. And when the pressure goes away, I feel better.
Can you do something to demonstrate, because we haven't talked about why we use that word pressure. Can you demonstrate a little bit about pressure?
Oh, yeah, sure. Demonstrate something about pressure. Okay. Okay. So why is everyone raising their hand? Pressure. And where did the pressure start? Started real lightly, didn't it? And what happened when y'all ignored the pressure? I increased it. Did I increase it in a way that felt unsafe to anyone? But I kept increasing it until you raised your hand, and then what happened with the pressure? Then the pressure went away. Because when I can figure out what makes pressure go away, and this is where the chemicals in our brain kick in, is that every time I figure out what makes pressure go away, I get a release of a neurotransmitter. Neurotransmitters are just chemicals that are produced in our brain that carry signals from one neuron to another. So if I want a signal to go from my brainstem up into my neocortex, then I'm going to have to produce a neurotransmitter that will carry that signal from one neuron to another. And as that chemical is produced, the neurons start to grow toward each other. And the more I can produce that chemical, the closer they're going to get, and the less of that chemical I'm going to need to get the same result. Okay? So when you figure out how to get that neurotransmitter to release, it's usually a neurotransmitter like dopamine that carries that release of pressure. And dopamine is a chemical that my brain produces that's an opiate. So it gives me just a little bit of feeling of I feel better. I feel calmer.
So we're going to use this word pressure because that can be transferred to lots and lots of different things. We also can sometimes talk about stress. There's other words that we can use there. Pressure tends to fit, we can fit all kinds of things under that word. Kids understand it. Every now and then we get people go, pressure's like this bad word for everybody. But it exists. So one of the things in our programming with families is we don't take away stuff that's just what is. So all of us in life experience pressure. So do all of our clients. There's no way around it. You cannot teach kids without there being some stress and pressure. It's just going to exist. There's going to be testing. They're going to have to do performance things. We have to help them figure out how to deal with that. Okay?
And their brains have been conditioned that when they feel any kind of pressure, they climb up the arousal continuum. So what we're going to do is we're going to keep working with them until they figure out how to handle that pressure differently. Instead of climbing up the arousal continuum, we want them to learn that when I calm down and relax and think, then I can figure out what makes that pressure go away in a way that doesn't damage myself or any of my other relationships. So when I'm in there with that Mustang and he's running around that pen, I'm not going to leave. Because then he's going to get that dopamine release that says, when I act this way, I feel better. And I don't want him to continue to act that way. So I'm going to pick a different option. I'm not going to release the pressure. So that just leaves me the choice of increasing the pressure or keeping it the same. And if I increase the pressure while he's resisting, there's two things that can happen. One, he's going to resist harder. That's one of the things that can happen. There's another thing that can happen that shows on one of these other slides.
Mm-hmm. So real quick, this is the thing lots of people think about with resistance. And this is when we see, Tim and I have been hired by organizations to come in and help them have fewer restraints or containments. We've worked with a couple different school systems about this, and most of the time when there's a humongous meltdown with a kid, it's because they were resisting and we increased the pressure, because that's pretty natural. Okay, we tend to want to do that. The other, if we don't want to do that, Tim knows his natural reaction with resistance is to want to increase it. We work with these kids all the time. Mine is to want to release it. I just want to be like, you know, I'll step out of the round pen. They're freaking out. I'm going to help them calm down by backing off. And when I do that, I'm teaching him exactly what Tim just said, is that resistance is what gets my needs met. So the other thing that can happen besides bigger resistance, I think it's here. This is a picture of a, so it's a picture of a horse that's being drugged by a car.
Increasing the pressure while the horse is resisting, and what's the horse doing? He's resisting harder. And that's what, we're all going to have our own tendencies about how we handle that.
But what may eventually happen here, and who knows what this led to, you know, why this was happening, but people do all kinds of crazy stuff to try to...
If he keeps pulling on that chain with that pickup, what's that horse eventually going to do? He's going to go forward, isn't he? Why? Because that's the only way he can survive. So he's going to appease. Appeasement comes from the survival part of the brain. I'm going to come forward so I can survive. And that's because the pressure was increased, and the only way I can survive this increase in pressure is to submit and to appease. But both of those things are going to damage our relationship. I don't want appeasement out of a relationship. So I'm not going to increase the pressure when they're resisting, because I don't want them to increase the resistance, and I don't want them to appease me. So I can't release the pressure. I can't increase the pressure. The only thing I can do is keep the pressure the same. Because if I keep the pressure the same, then this horse is going to have to figure out, what have I got to do to get the pressure to go away? It's safe. It's a safe environment to do that. I'm not pushing him further into the survival part of his brain. I'm pushing him up into the neocortex to figure that out. And that's what we want to do with our kids. We want to push them up into their neocortex so they can make a decision about what gets this pressure released.
So when we're talking about pressure, we break this down even further. This really comes down to like my body energy, okay? And this is why when you're working with kids who've experienced trauma, what's happening inside my body is so important. Okay, so if I've got a kid who's having a little bit of a meltdown and they're really, really resistant, I have to know what my natural tendencies are, okay? But let's say I start to get kind of pissed off because they're cussing me out and they just called me some nasty word and whatever else, or they spit in my face. We had a kid tell us the other day that happened. He spit in his teacher's face. She probably got pretty ticked. And when she did that, the important thing to know is that the minute you get ticked off, there are things that happen in your body, and your body energy comes up, and your heart rate comes up, and all of those things happen. And the minute you have gotten ticked off, you have just increased the pressure.
And that kid who is hypervigilant to everything going on in his world is going to know it without really even knowing he knows it. But he's going to experience that increase in pressure, which is going to make him resist harder or appease.
And so the important thing to remember about resistance is that it's happening in the survival part of the brain. If you look at your chart, in the limbic system, it's happening down in those lower regions. Every single time, if we increase pressure, and let's say they do appease us, a lot of kids will, especially younger kids, will do something to appease us. What we've done is continue to activate those lower regions, and we haven't done anything to build those cross-brain connections. So we're talking these principles. Tim and I get kids for an hour. We try real hard to teach parents some of the principles. But kids spend a lot of time at school. And at schools where a lot of times they're learning over and over again, if I throw a big enough fit, that's going to meet my needs. And so we're re-engaging those survival areas of the brain over and over and over again in their environment.
Which is going to make them better at it.
So the other thing they can do, they have 3 options. Anytime I make any request in the relationship, which is pressure, they can ignore, resist, or cooperate. Okay, so we've just talked quite a bit about the resistance piece. But we have plenty clients that will also ignore. And what ignoring means is, I could handle this kind of pressure all day long. You could keep doing what you're doing, and I could keep doing what I'm doing, and those ones are harder than this sometimes. We're going to talk about that. We'll move back a little bit.
And the Mustangs never ignored. They didn't have the capacity to ignore, because most ignoring comes from the neocortex. It's a conscious decision. So I had to teach them how to ignore.
Most ignoring. In dissociation, we're really talking about ignoring, and that's happening in the lower regions.
But it happens in the lower regions. So they can ignore, and I've still got the same 3 options. I can increase the pressure, I can decrease the pressure, or I can keep it the same. So if they're ignoring me, what happens if I decrease the pressure? Same thing. I'm teaching them that ignoring is what makes the pressure go away. And they're going to get really good at ignoring. So what happens if I keep it the same?
They've already said I could do this all day. This level of pressure does not bother me. And so they will keep ignoring.
So
kind of.
The only thing left for me to do is increase the pressure.
Y'all, they'll keep ignoring for a while until they get to where they're like, okay, you know what? If you don't mean it, quit asking me. And that's where you'll start to see some of those aggressive behaviors. Okay, like with the Mustangs, if they were ignoring and then we just kept releasing pressure, eventually when you walked in that pen, they would charge you and chase you out. With kids, you'll see it too. You can ask them to clean their room, but they ignore you and they don't do it. About the 5th or 6th day, they are like, you know what? Kind of, get the hell out. Quit coming in here and telling me to do that. They're not saying this, but what they're saying is, if you don't mean it, then quit bugging me. Okay, so eventually, if they're ignoring and you don't increase the pressure, you'll get some aggression.
Yeah, and we talk about it as being passive, being assertive, or being aggressive. If I'm aggressive, I'm going to create some aggression in my relationships. If I'm passive, I'm also going to create some aggression in my relationships. How many of you ever seen passive parents at Walmart that had passive kids? No, it doesn't work that way. They're going to become aggressive. So being passive or being aggressive is going to create aggression. So you have to find that balance to where I'm assertive. And that means I'm just using the amount of pressure it takes to get results. I'm not using any more and I'm not using any less.
That easy.
Yeah.
So with ignoring, there has to be an increase in pressure.
There has to be an increase, and that's what I did to y'all. When y'all ignored the pressure, I increased it a little bit. I didn't immediately go to cussing you out for not having your hand up, because that would have been too much of an increase in pressure, and it could have driven you from ignoring right into a state of resistance.
Some of you would have been like, oh, okay. If you started cussing. Others of you would have been like, and now nothing you do is going to get me to raise my hands. right? We'd have seen those reactions happen if the pressure increased too much. So the pressure has to increase, but in very small increments. Especially when you know with traumatized kids who move up that arousal continuum so quickly, we do have to increase it when they're ignoring. But we do it too fast a lot of times because we decide, you know, what our tolerance to pressure would be instead of paying attention to what theirs is.
And that's what we're talking about, self-control. We want our kids to learn how to control themselves appropriately, right? Can we teach them that if we're not going to do it? If their behavior causes me to get out of control, causes me to lose control of my breathing, my heart rate, my brain waves, my muscle tension, my eyes, can I really teach the kid how to control those things if I'm not going to do it? I'm kind of taking away his ability to do that. If I take away a kid's ability to ignore, or I take away his ability to resist, then he also doesn't have that choice that's going to happen in his neocortex. So having the choice to figure out how do I bring myself down that arousal continuum, not have you bring me down it, but have the choice to do the right thing, and the pressure's going to stay there until I do. Then when that connection up into the neocortex happens, it makes it possible to do it again. And the more I can make that connection up into that neocortex, the easier it's going to be for them to start to make that without me having to put as much pressure on them. It's like lifting weights. The more I lift 5 pounds, the quicker I'm going to get to where I can lift 10 pounds. So the more I use it, the more I make those connections in my brain, the better they're going to be at connecting.
So we have just a second. The general principles we're talking about when we're talking about trying to make changes into the brain, the first one is that in every situation, all children, but especially those who've experienced trauma, have to have the choice to ignore, resist, or cooperate. When they resist, if I take away that, we like to take away the option to even resist. And what we're doing is we're taking away the ability for their brain to start changing so they can learn. The other is that if they do resist, I keep the pressure the same. And that takes work on my part. And I think that's the hardest thing as mental health has become so big, especially in the school system, is it's not only our jobs to educate anymore, but it's that I can't sometimes educate because I've got a kid who just isn't ready for that. We have to help change their brains. Okay, and we do that when the pressure stays the same when there's resistance. That means resistance they can resist in a safe environment. They're allowed to do it. It's just not going to meet their needs. It will not work to get them what they want, but they do have the choice to do it. If they ignore, we've got to increase it.
And what we're really talking about is that trauma has set up these patterns in their brain of how they develop relationships and how they respond and react within those relationships. And that's what we want to change. We want to change those patterns of how they act within their relationships. We want them to figure out how to change those patterns. We can't change those patterns for them. It's connections they have to make in their brain to be able to change those patterns. And we're going to use a lot of sensory input to help them develop the ability to do that.
You have like 30 seconds.
Okay. And we can't really go into all the ways that we're going to do that, but that's what we're going to do. We're going to use a lot of sensory input. We're going to use the relationship with the horse to help them figure out how to change those patterns in their relationship. And we're going to teach them to do exactly what we're talking about. When I'm ignoring, when that horse is ignoring me, I've got to increase the pressure. When I'm ignoring, if someone cares about me, they've got to increase the pressure. When I'm resisting, they've got to keep the pressure on me. When I do the right thing, the pressure has to go away.
Totally go away.
Totally go away. And we even had one of our Asperger's kids tell his mother the other day, "Mom, you have got to quit releasing the pressure when I'm resisting. Can't you see what it's doing to me?"
Yeah. So I think let's end really quick. This is a real quick story, but we have a mother that we work with who's also a school teacher and has been working over the entire summer to learn these principles. And
We're seeing her son.
She came back after she'd started back to school, and Tim asked her, so how's school going? And she said, "It's awesome. It's going so well." And Tim said, "Well, yeah, new students will do that." And she goes, "Oh no, I moved up a grade, and now I'm with the same students I was last year." And Tim asked what had made the difference. And she said that she no longer was allowing her oppositional kids to control her. That she'd figured out how to keep the pressure the same within her body so that she'd made massive differences in her classroom, massive changes there. And so that's kind of where it starts. And we're out of time. So thank you all for having us.
Thank you.
Thanks very much. Really appreciate you coming. That was a great presentation. Again, this is another one of those presentations we could probably spend all day on, and you can condense it to an hour, so we really appreciate it. All right, welcome back from lunch. Thanks, everybody, for getting back on time. So we have another trauma-focused presentation from 1 o'clock to 2 o'clock. Then we'll have a break, and then following that will be the youth voice presentation from the Round Rock ISD team parents. So still got a lot to go, a lot of great presentations to come. I again want to thank all of the sponsors for lunch. I went back for seconds for that King Ranch casserole. And I also want to thank Heather for coordinating that lunch, because the food, this whole conference has been awesome. So thank you very much.
You're very welcome.
So I'd like to introduce Meg Hayden. Meg is also from Texas Neuro Rehab in the Ranch. And she's a licensed clinical social worker and a board-approved clinical supervisor. She obtained a bachelor's degree from UT Arlington, and after 5 years in the field, returned to obtain her master's degree in social work with an administration and planning concentration. Additionally, she completed studies in crisis theory, DBT, which she'll be presenting on today, and clinical supervision. In the past 19 years, she's worked in numerous arenas with a wide array of populations. She enjoys baseball, spending time with her family, and reading. Please help me in welcoming Meg Hayden.
Hi. It's always weird to hear yourself read off. You're like, what? Oh, I do like that stuff. Oh, wait, that's right. So as he said, my name is Meg. I work over at Texas Neuro Rehab, and we have lots of programs there. And I'm going to be talking more specifically about our ranch program. The only reason I say we're talking about that is that's where we're dealing with a lot of kids who may have crossed many of your paths at different times. But we utilize DBT down there as a tool with our kids. So I'm going to talk a little bit. There's this big picture DBT. When somebody says DBT, there's some very specific components that are part of a DBT program. What we do is we pull aspects of that, and I'm going to help you learn, hopefully, you can ask questions or whatever, about some of the aspects that you could pull and use on a regular basis with the kids that you're working with, hopefully. That's the goal. Just some basic facts about DBT, which is dialectical behavioral therapy. My kids like to call it diabolical behavioral therapy, but it really is dialectical. It came from 1970s and was developed by Marsha Linehan. Any of you guys know about Marsha Linehan by chance? Yeah, so she's a really fascinating woman, and she developed this a long time ago, and it was just about 2 years ago. There was an article, you know what I'm talking about, there was an article in the New York Times that she came clean, used self-disclosure, I shouldn't say came clean, but used self-disclosure that part of the reason she developed this program is that she had been diagnosed with borderline personality. As an adolescent, spent a long time locked up in hospitals. She hadn't shared that for a long time, went through, got her doctorate, did this whole program. Nobody knew any of that. And in the New York Times, they were talking to her, well, why now? And she said it was appropriate with a patient. It was the right time for self-disclosure to be appropriate. And it's just, I think that gives validity to the program in itself. So I like to share that part about it. So anyways, Marsha Linehan developed this program. It was initially geared towards borderline personality and suicidal patients. But a long time ago, I might be dating myself, I don't know where y'all fit with this, but it used to be that nobody thought there was anything you could do with borderline personalities. Borderline is what was kind of the, I hate to use the expression throwaway patient, but it kind of, there's nothing you can do for borderline patients. People wouldn't treat them, people wouldn't work with them. You know, they would work with them till they realized they were borderline and had this access to diagnosis, which after working with one for a little while, you realize pretty quickly there's this push-pull relationship with them, those kinds of things, and they'd go, oh, nope, they're borderline, you can't do anything with them, and wouldn't treat them. So this really was the first evidence-based program where you could work with borderline personalities, which is one of the toughest populations. It's not hard to see how we extrapolate that to working with adolescents, which is also a very tough population, especially in the current world where there's a lot of self-injurious behaviors, those kinds of things going on. But anyhow, the initial goal was to treat a borderline personality when she first brought it out, which we've now learned she had herself. And it can be used in a lot of settings. It can be used in an outpatient, inpatient, and residential. Initially, it was developed just for outpatient programming. As is true with most therapies, we just synthesize other therapies together and package them a little bit different, and now we have DBT. So if you're wondering where DBT comes from, really, a lot of the roots are in cognitive behavioral therapy, that kind of tried and true that we all know works, most research-based. And they added some Zen, some mindfulness, some being in the moment and present. And they added those, and those were the groundwork for it. It uses a combination, true DBT, and I'm going to separate those two, because when somebody says a DBT program, it means one thing. But a lot of people will just use DBT skills. In true DBT programs, there's several components. There's individual therapy that the patient attends once a week. There's a skills-based class that they attend once a week. On top of that, they have a diary card. The therapist is available for phone consultation, which a lot of therapists are like, ooh, no, writes it off right then. But it's, we'll talk a little bit more about that. It's a way of redirecting it back to them. And then professional consultation. It's always recommended that if you are treating patients with DBT, that you're in a consultation group where they essentially apply DBT to you to help you kind of get through it, because we know it's a difficult population. The skills training, and this is kind of the overview, we'll break all of this down, falls into four main categories. And this is the piece that really you can pull out and use elements with kids that you're working with. Mindfulness, being here in the present. Interpersonal effectiveness skills, how to negotiate and get what you want. Emotional regulation. With kids, that's a big one when we're talking about, I have kids all the time, well, I don't want you to just put me on meds. I like that I feel good and all those kinds of things, and I have this thing. And I talk about emotional regulation isn't saying that you don't feel emotions. It's not that you're not happy and sad. It's that we go from, I don't have a board in here I'm with kids. I draw an analogy. Emotional regulation is for kiddos who do, I'm assuming I can use this, like this. Emotional regulation means we're going to try and get it within like this parameter instead of kind of way out of control. Because these highs, these are mania. These lows, you know, suicidal feelings. We want you to have feelings, but we want you to be able to regulate them within a normal pattern. I don't use the word normal with kids. I heard a good line. It's a cycle on a washing machine. It's not really anything more than that. But we want to get it into something that they can utilize. So emotional regulation, and then distress tolerance, when things are out of control. When you are at the bottom of this line, and maybe you're not here, but even if you're like, feel yourself slipping down, what do you do in that moment to be able to get back? I'm stressed out, I need to be able to get back control. I tell teenagers all the time, if you've got those four things, you don't even need to be in treatment. You don't need to be with me. If you can be mindful, if you can regulate your emotions, if you can use distress tolerance, which is like using your coping skills when you need them, you know, we're putting it in words they get. And interpersonal effectiveness, you know how to manage working with difficult teachers, how to negotiate life with your parents, how to get through things. You don't need therapy. So look at it this way. You get these four skills, you're done if you can master those. It's based on a dialectical worldview and uses validation as an important tool. We're going to talk a lot more about validation because that's a really hard one for parents working with teenagers, to understand they can validate a kid without agreeing with them. Parents have a real hard time with that one. So DBT is based on the word dialectical, which is essentially you've got two opposing views and how to resolve the difference between the two of them. A dialectical view The whole focus is helping people balance acceptance with change. It is what it is, but things still have to change, right? And you have to be able to bring those two into balance. Validation is a real tool with DBT in your therapy components with them. It's something that's really important in working with teenagers in general. It doesn't mean you agree or understand. Parents really struggle with that. I cannot validate that because it's wrong. Okay, well, validation doesn't mean you're agreeing with it. It's understanding that that's how they feel. It's the true sense of empathy, right? I'm walking in their feet. I understand where they might be. It can be verbal or nonverbal. It can be, how many of you guys do counseling with kids or the opportunity to sit one-on-one with them for any reason? Okay, so have you found if you validate a kid, they're more likely and they're going to talk more? Yeah. And how do you validate? You guys all just validated me. You're like, mm-hmm, yep, mm-hmm. So that's a nonverbal and verbal way of validating. If you're validating where they're coming from, doesn't mean you agree with it. They're going to talk more, and you're going to get what you need in treating them. Validation for themselves and for others is important. They need to understand, and I pull on the parents because a lot of times it's that conflict between parent and kid that is the initial presenting problem sometimes with them, right? You know, they need to learn how to validate parents, understand their perspective, those kinds of things. Same thing. They don't have to agree with it. They have to acknowledge it. It does exist. It is the way they feel. It can be done very easily in the form of actively listening, staying focused, paying attention. If I'm sitting there talking to them and on my cell phone, we're in Therapy 101 here because we all know this, right? If I'm on my cell phone while I'm talking to a kid, am I present? No. Is my kid present if they're on their cell phone while they're talking to me? No. Headphones in, glasses down, those kinds of things. That's non-validating behavior. It says, I don't really care what you say. I'm not really listening to you, so it must not be important. Validation's key to getting them to go somewhere. In the formal DBT model, you have very specific goals of your treatment. Pre-treatment, you're getting your history. In a school setting, that may look like the referral from the teacher or from someone else. You know, they're telling you, oh, I need you to see this person, this and this and this is going on. Stage 1. Sometimes I'll even explain these stages to kids, sometimes I won't. But we're going to move from being out of control of one's behavior to being in control. A lot of times kids don't realize they're out of control of where their behavior is. Sometimes they do. Sometimes they can recognize this. A lot of times I'll ask them to draw their emotions through the course of a day. And a lot of them will do this exact, matter of fact, that's why I use it. It's because the kid was like, oh, I'm like this, and I'm good with that. Okay. Moving from being emotionally shut down to being able to feel my emotions. And that being okay. I'm never going to tell a kid not to be mad. I could be mad. It's that behavior that tacks to it, right? That ties into it. I can tell you not to be sad. That's sad stuff you're dealing with. Your mom's really sick. I can validate that. That's really sad, right? But how are we moving through that? Building on their ordinary life and solving ordinary problems. This is part where it comes from the borderline personality aspect. A lot of time with borderline personality, I've created this world, scenario, however you want to look at it, where it doesn't feel ordinary anymore. I'm going into extremes. The fact that something happened to me is leading to me cutting on myself and wanting to commit suicide. I have a very love-hate relationship where for somebody else, that emotion might be within this range. For me, that same behavior can send me way off. So we're kind of trying to bring things into an ordinary range. And then moving from incompleteness to completeness. A lot of people struggle relationship-wise, especially with borderline personalities. Really difficult to have an ongoing relationship with somebody. Because I'm like this. I'm all extreme, right? Who wants to be around me? That's too intense. So being able to have normal, healthy relationships. Truth be told, if you get all those things in perspective and you have good friends and you have a good support system, you don't need the therapy piece. It's when you don't have all of those that it comes into play. Does that make sense? Reasonable goals for treatment for our patients? Okay. So the first stage, the biggest thing we're worried about is life-threatening behaviors, right? Is this injurious behavior that we have life-threatening? You know, that's probably the hardest things with parents of teens that I've worked with is what to do when my kid's cutting on themselves. How to know the difference between are they suicidal, do I need to do something, when do I use extinction, all of those kinds of factors. The thing that I repeatedly tell parents is, no matter what, there's an issue going on because they're cutting, so we need to address it and work on it either way. And that's the fine line. You can't dismiss it, but at the same time, you can't give all your attention and focus because you're rewarding a behavior in there, right? So it's a really hard line. One of the hardest kids that I worked with, and this was a long time ago, I did ER social work for a long time, more than 10 years. And I worked with a kid long before it was the diagnosis everybody was getting as borderline personality. And he kept upping the ante. The kid was not really suicidal, but he'd cut his wrists, and his parents started ignoring that. So then he started saying he was going to kill himself, and then they started ignoring that. So then he had to step up the behavior. Well, this little pumpkin took 2 bottles of Tylenol. Because in his mind, it's just Tylenol. It's really not going to hurt me, but I'm going to prove to them. See, they'll see me take the pills, and now they'll know I'm serious. They'll validate what I feel because now they know I'm serious. The kiddo ended up, I don't know how much you guys know about Tylenol, but it's the worst thing to overdose on. Again, with the validation, thank you. Several of you know. I do a lot of education with kids on Tylenol. You think it's not a big deal. Tylenol will destroy your liver. And it doesn't do one of those, I'm going to go to sleep and not wake up, which is what people are looking for. It mocks cirrhosis down the road. You'll get a kid 3 days later, and it's very dangerous too, because the next day they wake up, think, oh, that didn't work, nothing happened, and they move on and never tell anybody. And meanwhile, their liver's being damaged. This kid was kind of that same scenario. It was the next day. He woke up. His parents said, I overdosed. They said, no, you really didn't. He said, the pills are gone. They finally brought him in. It was 24 hours that passed. That kid ended up on a vent in an ICU. He was intubated and put on a ventilator in ICU for 2 weeks. When he came out, and I was sitting there talking as he was crying, I didn't really want to die. This is not what I wanted. I don't want to die. He was looking for validation. He didn't want what was going on, but he didn't know how to get it, and parents weren't giving it. So decreasing life-threatening behaviors, and whether that means I'm actively suicidal or I'm doing high-risk behaviors or things of that nature that can be life-threatening. Therapy interfering behaviors. What's stopping you from getting to therapy? Why aren't you coming in? Decreasing quality of life interfering and learning skills to help people do the following. Control their attention, start new relationships, understand their emotions, and tolerate the pain. I promise we're going to get to the place where you can see where it applies to you guys. Wait, am I going the wrong way? Okay, the methods of meeting goals, and this is what we talked about. In true DBT programming, the way they're going to do that is they're going to do individual therapy. They're going to have a diary card where they track their feelings throughout the week and what tools they're using. They're going to go to a skills group. They're going to commit to attending a 12-week skills training program. And the skills is the big part because that is the piece where you guys will be able to pull out the phone consultation and the professional consultation from there. Here are the main treatment strategies. So we've set out, here's our goals. We want them to be healthy. We want them to be able to walk through all those. What are the actual strategies we're going to use in doing that? We're going to use dialectical thinking, problem solving, validation, stylistic, and case management. So dialectical strategies that you can use with your patient. And some of these are very specific ones that you can be using working with your client. Entering the paradox with them, helping them understand they do have some control. You have to have a rapport with the patient to be able to apply this one, but it is, well, I'm responsible for my behaviors. Yes, you are responsible for your behaviors, but if you're not willing to change them, we can't do therapy. So you can own that piece, but here's the piece that I do. Well, I'm going to kill myself. You have the right to kill yourself. But if you convince me that you're in imminent danger of killing yourself, I might get you locked up. Those are the things that you're tying into entering the paradox with them. You're not arguing with them. Okay, yeah, you're right. They do, right? We can't control their behaviors. How different would the world be if we could control teenagers? Actually, it'd probably be a worse place. But enter the paradox with them. You can use metaphors. Maybe they don't understand the communication that's going on. One of the best metaphors I heard came to me from a kid. We were talking about if you're in treatment, and this would be true if you have two kids that you just know aren't a good matchup. They're going to get each other in trouble, those kinds of things. the issue we were addressing with this one was they wanted to meet their new boyfriend and, you know, partial hospitalization, and we were talking about how that's not a good, a good plan, because nobody wants to hurt somebody else, but those relationships never end well. I've yet to hear the couple that met in treatment and lived happily ever after. Y'all know somebody? Please correct me if I'm wrong, but rarely does it end well. And so I'm trying to have this conversation with the kids and talking to them about it, and they're like, whatever, no, they understand me, they're going through the same things, I feel connected. And this one girl goes, you know, it's kind of like drowning. And I was like, what? And she goes, well, you know, I'm just trying to get above water. And they may not mean to, but if they're trying to get above water too, they might pull me down. And I was like, oh my gosh, that's the best metaphor ever. Used it with kids ever since. But it is. Nobody wants to hurt somebody else. So happened in Dallas, like a month after that, there was a family, I don't know if any of y'all may remember the story of like 5 people died. They were at a family reunion. One kid fell off a ledge and was drowning. Another kid went in to try and help and couldn't swim any better, and he went down. 5 people ended up dying. But it was that exact same scenario. Nobody was trying to hurt anybody, but I'm just trying to get above water myself. And in doing that, I'm pushing down the people around me and trying to get, you know, brace myself on something, and you're going to pull somebody down. But using that metaphor, especially because it came from another kid, helped the kids be able to see what we were talking about, how no one wants to hurt you, but that can happen when you get into this relationship. Playing the devil's advocate, that's pretty obvious. Extending is taking it one step further when you're working with a kid. So the kid says, if I don't talk to you tomorrow, I'm going to kill myself. Okay, I didn't realize you were that upset. Do we need to talk about going into the hospital? I'm not giving in to the desire for, like, I'm going to see you tomorrow, whatever, but I'm extending beyond that. Oh, okay, then are we saying we're suicidal? Because then that's a whole other story and we need to address that. So a tool for me is extending beyond what they say. Here's their threat. Okay, here's what we have to do with that. I'm not going to say, oh, no, you're not going to, obviously, because that would not be validating. I'm not going to dismiss that because I have to listen to them if they tell me that. So I jump to one step further. Are you telling me you're suicidal? Do we need to look at maybe getting you over to Shoal Creek tonight? It's extending, another technique you can use with them. Wise mind. Wise mind is my favorite thing. Oh, with DBT. And I will tell you why. Because kids relate to it. They don't when you just draw the picture. If you look in the fancy books with DBT, they'll talk about, and English teachers will see this as a Venn diagram. But can you see that over the other? Let me move. Does that one do a little bit better? Okay. So again, English teachers, here's your Venn diagram. Adolescents, for some reason, they think it looks like a butt. I don't know. That's what they tell me. But you have these 2 circles overlapping, right? And one of them is your logical mind, and one of them is your emotional mind. We talk to kids. What happens if you make all your decisions logically? Will y'all tell? Did I spell that right? Tell me, what happens if you made all your decisions with your mind? Is that good? What? With the logical mind. Uh-huh. If all your decisions are logical, what happens?
You're robotic in a relationship.
Yeah, you're very robotic in everything you do. You might lose emotion. What else? I mean, is it good to make all your decisions? What if you make all your decisions emotionally? You're a wreck. Absolutely. And usually most kids are over in this. You'll get some that are over here. But so what we talk about, the wise mind is right here, where these 2 overlap. This is the wise mind. This is where we want to make our decisions. Because it is important. When your parents are preaching to you, and I'm talking to y'all like you're teenagers, they're talking from their logical mind. When you're hearing it, you're in your emotional place. But I love him. That's all emotional. And your parents are like, he's bad for you. That's all logical, right? But here's where good decisions make. This is what we're looking at. So I'm talking to you. Is this decision made with your wise mind? This decision we're talking about right now, where's it coming from? And help them look at where it's coming from. An easy tool to pull out with the kids. Teenagers get this really well when I go, this is about bringing your heart and your head in line, right? So if I don't want to get caught up in logical and emotional, your heart, what you feeling, what's going on? Your head, what's it telling you? When those 2 start to cross over, That's the wise mind. That's where good decisions are made. And that's where we want our kids to make decisions, right? We don't want them to be robotic. We don't want them to be over the top based on emotions. Turning negatives into positives, lemons to lemonade. You guys probably know that drill with a kid. Natural change, natural consequences, kind of just walking through what's going to happen if we don't do anything with what's going on. And assessing dialectically, asking if we're looking at all the pictures. What are we missing? What's missing from this when we're talking about it, and helping them do that. So all very specific things when you're talking to a kid to help them. Problem-solving strategies. These are all the different problem-solving strategies you can use with a kid. Behavioral analysis. Now, kids don't usually, so clinically we're going to go, okay, what's the reward the kid's getting? Are they getting attention? Are they getting these things? Do we remove the positive reinforcement if you're getting real kind of behavioral therapy part? One of the ways I will use that with kids is I'll make them do a timeline. This particular, I don't know why pumpkin's the word that's sticking in my mind today, but this little pumpkin that I worked with, he got in all kinds of trouble at home, and I asked him to put 12 hours on a timeline. And so we did our own kind of, but at his level, behavioral analysis, where he's like, well, here I'm at, what's the acute care psych hospital y'all go to here? Where do y'all go? Shoal Creek still? Or is there another? Okay. Shoal Creek or Cedar Crest, okay. So what happened last night? My parents put me back in Shoal Creek. Okay, so here's our point right here at Shoal Creek. Let's work backwards. And then just walking through the steps with him. Okay, so what happened right before you went to Shoal Creek? I don't know, my dad just went off. Okay, so your dad went off. What was going on with you? And I'll tell him, okay, let's pretend you're outside like filming it like a movie. What am I going to see when that's going on? Well, I was tearing up my room. Okay, so you're tearing up your room. And so we'll put that on here. Okay, so what happened right before that? Well, my dad got mad at me and told me to go to my room. So it's all still the dad's fault at this point, right? So what we're doing actually is we work back to where Dad first asked me a question, which is way back over here, and I lied, that started this part. And then Dad challenged me, and I got real obstinate. I mean, these aren't the words the kid's going to use, right? But this is what's going on. We're seeing this pattern happening. So you get the behaviors and you map them out. So then you're just looking back at it. Huh. So yeah, you ended up at Shoal Creek last night. Look at that path. Where on there could something have gone differently? What did you have control over, right? Because you want control. What did you have control over? Well, I could have not torn up my room. Okay, so you could have changed it all right here. Cool. Anywhere else? Well, maybe if I hadn't said F you to my dad. Okay, so back here, things could have changed. What would have happened if you didn't say F you? Well, none of this would have happened. Oh, okay, okay. Anything else you had control over? Well, I didn't have to lie. Oh, what would have happened if you would have told the truth? I still would have gotten in trouble. Okay, so something might have still escalated from here, but not to Shoal Creek, right? Yeah. Okay. Huh, okay, well, that's a pretty good picture. Anything else? Well, I could have not snuck out with my girlfriend in the first place. Okay, because now we're adding to all the things that we could do that didn't lead up to here. But through that behavioral analysis, the kid starts to see, because teenagers, it's all about, for all of us, it's all about control, right? What we control. What did you get control over? Because when they walked in, all I saw is my dad put me in Shoal Creek. I don't have any control. My dad stuck me in Cedar Crest last night. Okay, show me where you had control. Solution analysis, you're brainstorming. Okay, well, what can we do? You know, Tommy hates Joey, and I'm tired of being in the middle, and da-da-da-da. Okay, so solution analysis really just helping them brainstorm. Doing that good old-fashioned pros and cons based on the brainstorming. Skills training, and I'm going to table that one because we're going to talk some of the specific DBT skills training in just a minute. Contingency planning, exposure, there are treatment modalities you've seen in other places, like exposure, for example, stair-stepping them into situations. With adults with chemical dependency, one of our programs we have, we go to Walgreens. It's exposure therapy. People are like, what, Walgreens? I'm like, yeah. They have to walk past the beer and liquor aisle. We go bowling. Do you know how hard it is to go bowling and not get a beer if you're an addict? Because that's what you do. I mean, honestly, that's what I do, right? But to go into that same environment, that exposure with the treatment team. At the ranch, we take kids on outings every week. It's what they want to go do, and they think, oh, it's all just fun and games. Oh, God, we got to go bowling or whatever. But when you talk about, well, how did the social skills go? How did those kinds of things go? You know, that experiential piece really adds into it. But the exposure is exposing them to those triggers that we know they're going to set them off in a safe environment, processing how they manage through it, and planning for the next level. And then cognitive modification, changing thinking patterns. Can go into a whole another speech about that one, but we'll leave it with like Beck and automatic thinking. You know, what are they thinking that's leading them to the behaviors that's getting them into trouble? Anything specific so far that you can see yourself using with any of your kids? Yeah, somebody tell me one of the things you could see. The timeline. So tell me, what kind of kid would you use the timeline with?
One that is confrontational with the teacher, and then it's always the teacher's fault.
Of course.
And, once they're down in either my office, in the counseling office, or in the principal's office, being able to start, okay, here we are now, you know, working back and helping them see where they could have had that they've had control all along.
Absolutely. Good. Yeah, ownership, accountability. Giving them that control, right? That's what they want is control. Fine, take it. But what part do you have control over? All right. Validation, and we talked a little bit how important validation is. I'm looking at times to see how much we want to go into this. The biggest thing with validation, and I'll say this 500 times over while we're talking, is parents. Because parents have a really hard, and I get it. I'm a parent of a teenager. I get it. It's hard because you think if you say, you validate, it's like you're sending a message that it's okay, and I don't want them to have that message that I think it's okay. But you balance that with the kiddo that ends up in ICU because he never could get any validation or acknowledgement of how he's feeling. It's a big trade-off. So being able to learn how to validate your kiddos is really important. Stylistic strategies, when you're actually talking with the patient. Reciprocal communication is that warm, genuine, empathetic. It's what we all learn about when we're talking about counseling, how you engage a kid, those kinds of things. Irreverent communication is really kind of the opposite. It's trying to throw them a little bit off balance. It's usually done very deadpan. It might be considered kind of humorous for somebody outside looking in, but in the moment, that's not the intention. Irreverent communication would be, I'm going to kill myself tonight. I thought you weren't going to stop therapy. What? I'm never going to see you again. I don't want to be in therapy. Okay, do you need a referral? That's not what they're looking for. If they're saying that, they want you to go, no, you need to be here, that kind of thing. So just kind of throwing them off, but then they go, what? What did you say? Rapport is important in that one because they could take it the wrong way. I mean, you can use irreverent communication going, are you serious? Are you kidding me? Like, because a therapist isn't supposed to do that, right? We're supposed to sit and listen and be quiet. But anything that's throwing them off balance, because it makes them stop and think, what? Wait, what did you just say? I just told you I was going to kill myself and you're going to cancel my appointment for tomorrow? That's not what's supposed to, but the whole point is to stop where things are right then and throw them off balance and then come back to ground. So it's a different type of communication that you can utilize with them. Again, you want to make sure you have a rapport with them because that could also throw them on the flip side. Case management in DBT is very different because you're seeing yourself as a teacher or a coach. When you're consulting with the patient, let me apply this in a school setting. So the kid's really upset with their teacher. They have all these problems with the teacher. Consulting with the patient is teaching the patient how to go talk to the teacher. You're not interfering. You need to talk, teaching, educating skills, training them how to be the one that does the consultation. Can you call my mom and tell her that Math 101 is too hard for me? Or, whatever the case is. So your shift in this place is teaching them, what are you doing? With a parent, it may be they've just told you something that you probably need to report to Child Protective Services. Well, instead, maybe you sit with them, talk to them about them reporting. Let's sit together. Why don't you pick up the phone and call? So you're showing I have some faith in you and support, and we're going to sit here and do this together. But you're pushing them to be the advocate for themselves. You're not doing it. Environmental intervention is when you do have to step in, and the only time you're going to use that with DBT is if somebody's at risk. So if I don't step in, this kid's going to kill himself. If I don't step in, it's not if I don't step in, the kid's not going to get to go to the party Saturday night, right? It's if there's a serious issue at play, they're not going to call CPS themselves. You can't get them to do it. You have to step in and call CPS, period, the end, right? So those are the environmental interventions. And consultation is You're getting help. It is. I'm dealing with all these kids. I'm applying DBT. It's a tough group of people. The consultations with me, when it talks about consultation team meeting, I'm going in and I'm in a group, and DBT, they always recommend that you're getting DBT applied to you. You're getting the skills you need to deal with the kiddos, that you're getting the support that you need. So consultation team meeting is when you're talking about the therapist themselves getting treatment. There's the making the child do it or helping them do it. There's that, nope, I have to step in because we're talking imminent danger. And then there's, ooh, this is so much bigger than me. I got to step out and talk to somebody else altogether to manage this case. Okay, this is the part that people usually are most interested in. I'm going to preach 2 books to you guys. Dialectical Behavioral Therapy with Suicidal Adolescents is a great book. And this is the tried and true original DBT manual. You will see other ones. There's a green one you can get at the bookstore. There's lots of different versions of that. There's a couple things I might talk about that Marsha Linehan's a very smart businesswoman too, that I couldn't put slides in from here because they're copyrighted. I even requested it, and she's like, no. So some things, and I'll apologize, I'm going to pull straight from the book and talk to you about because I couldn't put them in your slide. This book is really important because they have a special section called Middle Path, which is specifically applying these skills, working with teenagers and kids. And we toss that back and just circle it around if people want to see it. I think it's on your resource book, at the end of your sheet. But the original guide breaks all your skills training. Remember me saying that they have to go to a once-a-week skills training while they're in the program. And then really the individual therapy is just saying, hey, did you go practice that skill this week? How'd it work for you? What's going on? The 4 areas, the first one is mindfulness. And of course, the wise mind that we talked about. I'm going to pass out some Hershey Kisses for me. With mindfulness, I'm going to ask you guys to grab a Hershey Kiss, but don't do anything with it. Just set it in front of you for a few minutes while I'm talking. Mindfulness, and the way I talk to kids about mindfulness is, who remembers Lion King? So my kids were little with Lion King. I know that's probably not, it's probably a dated reference now, but so in the Lion King, there's a scene where, was it Simba, the little baby lion, right, is talking to the baboon, and he hits him over the head with a stick. And the little guy goes, what'd you do that for? And he said, it doesn't matter, it's in the past. That's essentially what mindfulness is. It's about being present. Whenever somebody shows up in front of you and there's stuff going on with them, it's not what's imminent right then, because they're standing in front of you, they're healthy, they're right there. It's either what happened to them in the past, or it's their fear over what's going to happen to them in the future about something that they're doing. It's not about the here and now. And mindfulness helps you get into the here and now so that you can have some perspective. Mindfulness isn't just zoning out or ignoring something or making your mind go blank. It's actually the exact opposite. It is being so in tune to what's going on that it makes you focus very much in the present. A good example with kids, little kids, is tying your shoe. You know, if you have little kids, or if you remember when you were learning to tie your shoe, okay, there's the bunny ear, and you loop around and you go through. And remember how hard that was? Whether it was you were teaching another kid, like over and over, I can't get it, and it's it. You're very mindful. You paid so much attention to how you go over and you go around and you loop through. When was the last time you thought about when you tied your shoes? Probably do it pretty mindlessly now. Done, right? But when you're learning, you're very mindful. You're thinking about every step. When you're 16, you're learning how to drive a car, or 15, whatever age you're figuring it out, 18, 25. But you're figuring out how to drive a car. Remember, okay, check the mirrors, 10 and 2, seatbelt done. No. Do y'all do that when you get in your car? Do you do like, what was that, like an 11-point check or something? You get in your car and you're like, mirror, mirror, seatbelt, 2 and 2, you know. And they don't ever mention getting the radio where you want it to be, right? But you're so mindful when you're first learning. Now we just get in the car and you know, we're at 7-Eleven before we even realized that we got in our car. Or we drove home from work and we're like, oh, that's my exit, you know, because we're being very mindless. So it's not just ignoring what's going on, it's being very present and helping get some perspective on the here and now. The basicness of mindfulness is what skills and how skills. What skills are, we're trying to remove judgment when we're doing mindfulness. It's not about what's right and wrong. It's about what is, right? Observe something, describe it, participating in it. How skills, how you do it non-judgefully, open-mindedly, and effectively. In the book that's circling around in the back, there's 40 or 50 different mindfulness activities. If somebody's doing, again, I'm going to go to that, true DBT training, every skills is going to start with mindfulness because that's how important it is. It is the crux and the start of it. So what we're going to do is we're going to eat our M&M, our Hershey Kiss mindfully. A great activity with kids actually are those little cutie oranges. Do you know what I'm talking about? Because they have a great smell and a feel and all that kind of stuff. So I'm going to ask you for a minute, just look at your Hershey Kiss. Don't touch it. Just observe it. If you had to describe to somebody what it looks like. Is the tinfoil all wrinkly, right? When was the last time you looked at one? Like, if you're like me, you just go, and you've eaten it before you even know what color the wrapper was, right? You only know that because you don't know if it has an almond in it or not or something, right? So observe it for a second. Remember the little flag? What, do you know it actually says Hershey's? What if I snuck one in there and it said something different? Which it didn't. I'm not that clever. But you know what I mean? Like, we just assume that the little flag says Hershey's, the tin foil's there. But really look at it for a second. Open it. Is it hard to open? When you're trying to do it mindfully, it's a little slower to do it. With kids, you're noticing all different kinds of things about it, right? Don't eat it yet. If you're like me and mindless, it's probably already in your mouth. I love this. She's straightening out the flag. Make sure it's real clean. Some people have their Hershey Kiss still sitting in it. Some have it all flattened out. They're straightening out their little tin foil in front of them. Smell it. Still, we're not eating it yet. Smell it. It's last time you smelled chocolate. Yummy. Okay, so unless you're allergic to chocolate, nobody sue me if you're allergic to chocolate, put it in your mouth and just let it sit there for a minute. What? Are diabetic. If you know you should take control, if you know you should not be eating chocolate, please do not eat the chocolate. You have this control. I don't want to go. I'm at the hospital. Why? Because she gave me chocolate. Why? Because your control's here. I don't have to eat it. But if you're comfortable with it, eat the chocolate. Just let it sit in your mouth for a minute. Sit smooth. Do you usually let it sit in your mouth, or you just swallow it or take a chomp and let it go? Chomp. Yep. Down. All right, eat it however you want to eat it now. So anyways, but was it a different experience? Do you remember what Hershey Kisses taste like? Right? It's completely different. With kids, a great one, like I said, is the little oranges, the cuties, because they smell. You make them smell them. And you peel them, and you look at the peel, and you look at the orange, and the segments are, divided equally, those kinds of stuff. I challenged kids one day to go home and do something mindfully. I didn't care what it was. Make a peanut butter jelly sandwich. Tie your shoe. Learn a new skill, but do something mindful. And the thing that came back was this one kid goes, "Oh my gosh, I had a cigarette in my mouth and I didn't know it." And I was like, "What?" And he goes, in the moment I stopped and I was trying to be mindful and I realized that I already mindlessly pulled out a cigarette, put it in my mouth, lit it. I didn't want a cigarette. I didn't need it. I just was smoking. And I was like, huh. So when they bring attention to those kinds of things for themselves, what are you doing mindlessly in your life and what are you doing mindful? Because again, usually the issue that's going on for you is not right this moment. It's something that happened to you before, or it's something that you're scared is going to happen to you in the future. It's not right now. How many times are you in your car and you're driving home and somebody just cut you off? And you are cussing them and so angry and still driving and then you missed your pass. Like you lost a whole period of time and you're still angry and you get home and you kick the dog. No, hopefully y'all don't kick your dogs. But it's all about what happened to you when some guy cut you off 10 minutes ago. So if I stop and become mindful, I let that go and I'm here. It's kind of like a do-over. It's like, okay, no, I'm here. And right here, I'm safe. And right here, I'm healthy. And right here, I'm with somebody who wants to help me, ideally. So mindfulness skills are really important. And it really is about what skills and how skills. And one of the things you're teaching kids, too, is, you know what, judgments are going to come up in your mind. It's part of life. You're going to be like, what? Why is this crazy lady making me eat chocolate? But that's not what I want you focused on. I want you focused on the chocolate. So you just let it go. You don't judge yourself. Oh, my gosh, why am I off topic? Why can't I pay attention to what's going on? If they come up, you let it go. You can teach skills with them. I talk about laying on the ground and you're just looking at the sky, and as ideas come up, if they're judgmental or whatever, you just let them float by. Don't grapple with them. Don't argue with them. Just let them go. Judgment will come in. It's part of it. But letting it just float on out and not become what you're focused on is a big thing. Okay, so that's mindfulness, and there's lots of mindfulness skills that you can do with them. Interpersonal effectiveness. Very specific ones in this red book. For each of these 4 categories, there are 4 very specific skills. And in this book, and I'll float this one around too, there's a 1-page handout that if you buy the book, you can copy and give to clients, but technically you're not supposed to use them in professional stuff, and I'm trying to be ethical here. So let me find if Dear Man's in here. Dear Man I use with talking to kids about getting what they want with their parents. It's because it's interpersonal effectiveness. What it is when I'm talking to kids, like that's how you get what you want. That's how you figure out how to get things. So Dear Man is just an acronym, as almost all of these are. Dear Man is describe, express, assert, reinforce, be mindful, appear confident, and negotiate. So as a counselor, if you're talking to them about how to go talk to their teacher about something, let's talk about Dear Man. Describe what you want. Express what you want. Assert what you want. Reinforce it. You know what? I feel I'm always getting picked on I feel like I'm getting picked on when I'm in math. I don't want to be picked on. Let's stop, that piece. And then the mindfulness comes in when you have the reciprocal part of the conversation. You're going to be listening. You're going to be very present when they're saying what's going on. You're going to appear confident. You're going to say, well, I understand, but this is where I am. And then you negotiate. But you go and you present. I work with kids. Sometimes I have to prepare the parents ahead of time. I'm like, give the kid a win. We're going to practice Dear Man, right? And they're going to come. And I help them negotiate something I know they're going to be able to win. You know what I mean? Like, I'm not going to... I want them to sign that I'm 15 and I can marry Joe Bob. Yeah, I don't care if you use Dear Man, that's not going to happen. But I tell them to start with something little, because essentially what you're teaching them is how to speak up for themselves, listen to the other person, and then negotiate and get what you want. And then you follow up the next day. How did that go? That's the crucial part for us, right? How did that go? Because if it didn't go well, they're going to go, oh, that's the stupidest thing. I'm not going back to her, or I'm not going to follow up on that. Instead of being able to problem solve and loop back around, well, it didn't go well. Well, why not? What do we need to work on? What's missing in this skill? So all of these are acronyms. They're all, and I will tell you, if you choose to utilize this book, you could just pull this out and do this sheet, and you can just ring it by Dear Man. But if you read the section with it, it actually even gives you talking points. It's almost a cookbook for doing the skills for it. So, emotional regulation. And again, with emotional regulation, we don't want them to kill off their emotions. We want them to get into a range, right? We don't want the really high highs, mania, not sleeping, using crack. We don't want the really low lows. Can't get out of bed, can't get to school, takes too much energy to get out of bed, might as well die. So in emotional regulation, again, all of these are activities listed specifically in here, and I'm pushing up on time, so I'm not going to go through all of them. But if anybody wants to look at that, we can send that one around too. Distress tolerance. Distress tolerance is, again, it's kind of like coping skills. We all use that word, coping skills. Kids who have ever been in treatment hate the word coping skills. Coping skills don't work. I don't like coping skills. Do not use the word coping skills. I'm using it with y'all, but kids get really offended by it. Because they can all recite 20 coping skills. They can all tell you, oh, I sing, I journal, I do this, I do that. That's not the issue. It's doing the right thing at the right time. That's the real kicker, right? I don't care if you can tell me what your coping skills are. Can you use them in the moment? And walking through particular skills can help them do that. For example, self-soothe is one. Actually, I use that one. I like that one a lot. Self-soothe talks about how you're taking care of yourself, and the more senses you can use when you're taking care of yourself, the better off you are. And I'm going to incorporate some mindfulness into this. So for me, I love hot tea. I want to use all the senses I can when I'm trying to take care of myself. So I make sure I have a porcelain cup so I can feel the warmth, especially if it's cold outside. I have a cup that's Far Side. Y'all know what Far Side is? Goofy cartoons. It's got a crisis clinic going off a waterfall on it. So visually, it makes me laugh. I'm feeling it because it's warm. I get teas that smell really good. And they're warm when I drink them, and they taste good. I've used all of my senses. And in that, I'm becoming very mindful, right? Because I want to be mindful of the fact that I'm using all my senses. And it brings me to the present, and it soothes myself. I talk to kids frequently about making their own box. I talk to kids who go back to school from us about what they carry in their backpack. What can you carry in your backpack to self-soothe? Girls, a lot of times, smelly good lotions. Whether you're into aromatherapy or not, because you're rubbing and that feels good. We'll talk about pressure spots in their wrist that they can rub on that can, I mean, not in their wrist, in their palm, that can make them feel good. Make sure you smell it, put it on. You know, we talk about different things. Have a little toolbox in your backpack of what you can do. They don't need to know that you're using a skill. You know, how do you mask it? They don't want to show that stuff. So those are distress tolerance skills. Walking the middle path. What they found in research, and there's a whole section in the textbook one that I sent around called Walking the Middle Path. When they did a lot of research and they started applying all this stuff that we know works with borderline personality, and you can see how that works with other people because, well, I don't think I'm borderline personality, but most borderlines don't think they're borderline. But I use some of those skills on a regular basis. Like, seriously, I will use the self-soothe, oh my gosh, I got to go deal with this kid, and I do not want to deal with this kid. But what we found is that the struggles with walking the middle path were parents being able to relate to what's going on. So the middle path is a DBT program that's specific to teenagers and parents, and the parents go through the skills training too. So they know what they're looking like. They can help prompt the kids to use the skills, you know, hey, do we need to be using this, that kind of thing. And they add, the thing they found that parents really struggle with, and we know this is validation, parents really struggle with being able to validate their kid in a way that the kid feels validated and the parent feels okay about it. So there's a much bigger focus in Walking the Middle Path than you'll find in that red and black book, because it focuses on the issues that teenage parents tend to have the hardest time with. Research with teens. Oh, this did have it in it. I didn't see this slide earlier. Okay, so how do we know that this program that was built for, I mean, I hope you guys can see how you could apply some of this stuff with your kids and other folks that you're working with. But of course, we have to be evidence-based and not just believe that, oh, that sounds good, I'm going to try that, right? So they've actually done a lot of research on applying DBT to adolescents. There's an outpatient program in the Bronx with a mean age of 16. A lot of them had, and the parasuicidal behavior is the cutting, you know. It can be other attempts, but for the most part, what they were working with were kids that were cutting. They modified the program, which they were teaching mindfulness 3 times a week, and modified the handouts. They didn't use the middle path. They modified the original Linahans. The kids were more likely to complete treatment, fewer psychiatric hospitalizations, decrease in suicidal ideation, and standardized tests that were looking on happiness in life and depression all increased when they used the program. Another program with juvenile offenders in a mental health cottage. The skills were taught and reinforced in the milieu, and the consultative team was in place. So what wasn't happening is that individual therapy may not be using it in the same way. The phone consultation pieces weren't being used. But we just were teaching the skills and reinforcing those skills in the milieu. And the behavioral problems were significantly higher in the experimental, but the cottage that weren't using it. And there were fewer punitive responses. And by punitive responses, what they were talking about, and they gave examples, was the kids not being able to go on outings because of bad behaviors, those kinds of things. That lowered. So their behaviors were improving, and therefore they weren't getting as much trouble. They weren't losing their levels when they were in level systems. They were being able to do more things by applying the DBT with the kids. Okay, conclusions. Oh, 5 minutes, yes. DBT is an evidence-based program that's been proven effective in treating borderline personality disorder and suicidal adolescents. DBT incorporates individual therapy, skills training, and consultation to treat patients. DBT utilizes didactics to balance acceptance with change. One of the examples I use with kids a lot of times, and I'm big on the metaphor piece in case you haven't caught that, was if you get pushed off, a lot of times kids want to flounder about, well, it's not my fault and this kind of thing and the other. And the analogy I use is, you know what, if you're on a cruise ship and somebody pushes you off that cruise ship and you end up in the water, yeah, it sucks, and they push you off, but the reality is you're going to sink or swim, and you have to decide it doesn't really matter at that point, because here's where you are. And in that moment, you have to be able to balance acceptance. I'm in the water, and I'm going to drown if I don't do something. With change, I got to do something, right? So we can complain about who pushed us off the boat and everything else, but we're in the water, so it's on us to sink or swim. And then, of course, the 4 components to the skill training: the mindfulness, interpersonal effectiveness, emotional regulation, and distress tolerance. It's a lot to cover in an hour, but it really is an overview. And I think on here I have the book that I listed in there. Yep, with Suicidal Adolescence, the 2007 is the book I was talking about that has some really good information on it. You will find a lot, even just doing a Google search, you will find a lot about DBT. One of the things I did not mention, and partly because it was one of the things copyrighted and I don't really use it in my program, is a diary card. You may hear that terminology when you're hearing about DBT. And what a diary card is, where's the red and black book? I'll show an example of it really quick. Will you see the diary card? I think it's one of the ones flagged. What they do with the diary card is, so we teach the kids, sorry, y'all seen all my chicken scratching here. We're teaching kids skills, right? Here are the skills that we've taught the kids. With a diary card, we send them home with a piece of paper. I have used a modified version of it, but this was one of the things she wouldn't allow me to copy, where you just list the skills and then you talk to them about using it. When I mentioned phone consultation, when they call you in crisis, we're not resolving the crisis for them. We're asking what skill they've used. It's all about bringing them back to the skills. Because in DBT, really the thought is if you don't have the you don't need to be doing trauma work if you don't have the skills to deal with it, right? So the first step in DBT, they're not going to deal with trauma and all that kind of stuff. We want to get there, and I know y'all just had a great presentation on trauma, but they have to be able to handle it to go there, right? And so part of that premise with DBT is let's give you the skills so you can manage it, and so then if we need to go further. Because when we're doing the phone consultation part I was talking about, we're not going into their trauma and all that kind of stuff. We're helping them have the skills to get their things under control. And then, if we need to go into the other aspects, we are. But we're helping them be able to manage what's going on. Questions? Comments? Ideas? Yes?
Can you give an example of what validation would look like from a teen, from a mom to a teen, or from a parent to a teen? When you say validate, how does that look?
So, you know, a lot of times it's about acknowledging the feeling. It's not about acknowledging the behavior. And that's what parents usually need to hear. So if I'm going to go on about, let me think of a good example. I'm upset, my behaviors are crazy, and somewhere in there I've acknowledged that I'm sad or grieving or something like that. You're going to acknowledge that piece. Wow, you're really upset. You can even give the words back to them. You're not agreeing with them, but you're just saying back to them what they just said to you. I hate this place. Wow, you really hate this place. You're not acknowledging whether they should or shouldn't hate that place. You're just validating, I heard you. I get it. I'm there. So a lot of times it can just be giving back their own words. A lot of times it's finding the feeling and what's going on and validating that. And that sometimes helps parents because they get real focused on not wanting to validate a behavior. But you're validating where they're feeling, where they're coming from. You're teaching them to be you're essentially teaching people to be empathetic with validation. You know, you don't have to agree with the behavior. You just have to acknowledge, I mean, it is what it is, right? It's the same thing with the being in the water. You're in the water, so, and that sucks. And it's okay to say to a kid, yeah, that sucks. I mean, if you stop and put yourself in their shoes, I wouldn't want to be a teenager nowadays for all the money in the world, right? So if they're feeling out of control and overwhelmed, instead of going, man, you don't know overwhelmed. These are the best years of your life. You're not paying the bills. You're not, you know. Stop for a minute, because that's where the parents go, right? That's where I go sometimes. Because it seems like it's so, you know, you don't have any real stressors. But that's not where they are. That's not where they feel. So you're validating where they are, starting where the client is if you're a social worker. That's like ingrained in us. It's a good question. Any other questions? Okay. Thank you guys very much. I also have, just if anybody wants to look at it, because the new DSM came out. I'm sure many of you know that. There are a lot of changes. There's a whole separate category on autism spectrum and lots of different stuff. But if you're anything like me, I got peace in just looking at it because it's not structured that differently than the old DSM. So if you want to look at it, I will leave it around so you can.